Okay, good afternoon, everyone. South Africa, UK, if there's anyone from UK, and I'm sure people are familiar with this webinars that we have. It's the last one this month. Maybe in the future, we're going to have some. So good afternoon. So we're very privileged to have Dr. Solomon, a colleague that I used to work with, where I currently work in a community mental health team for older people. So I know she's moved on, working as a consultant old age psychiatrist somewhere in London. I don't know where. So she'll actually introduce herself. So we welcome you, Dr. Solomon. Thank you so much for giving your time to come and share your knowledge in mental illness in older people. Thank you very much.
Thank you, Zetu. Thank you so much for inviting me. So I worked with Zetu quite well over a year ago, and now for the last just over a year, I've been working on an old age inpatient psychiatry ward, working with a sort of a range of patients who have either dementia or other sort of mental illnesses. So I hope that I can give you a bit of a sort of an overview of my experience working with mental illness in older people, and sort of answer any questions. If there's anything that anybody doesn't understand, please just sort of feel free to put something in the chat or interrupt. Um, I've done it as sort of an overview, at a level I hope is understandable. If there's anything, like any terms that anyone doesn't understand, again, just ask me to explain and I can stop. So I'm going to go through a few things. So firstly, think a little bit about why it's important to think about mental illness in older adults. Talk a bit about what mental illness is in terms of diagnosis, how it presents in terms of symptoms, what some of the causes are, certain risk factors in older adults, a little bit about physical health aspects, some of the treatments, and then thinking about how we try and understand and how we and try and help and support older adults who do have mental illness, and then think a little bit also about the impact on carers, because often with older adults there are people around them that are involved very very closely in their care, and there's sort of a secondary impact on them. So one thing I thought about when I started was, well, what is actually the definition of old age? Because actually, it's something that's probably not clear cut. Sometimes some people would sort of give a particular age as a cutoff. Well, if you're over 60, then you're old. But actually, I think it can really vary, probably in different countries, sort of across the world. And it's probably changed over the years because, as life expectancy has increased, obviously, what people are able to do and how long people are fit and healthy also changes what's defined as old. So I think it can sometimes be subjective how a person feels, objective in terms of how we view things as health professionals. But in the UK, we use a cutoff of 65 years as old age, and I, as a doctor, have actually seen people who can look very different. So one person who's in their 50s almost can look very frail and elderly, compared to somebody who's in their 70s who could look almost like they're in their 50s. So I think we have these cut-offs, but it's not necessarily clear cut. In terms of describing what a mental disorder is, so this is a definition I got from the WHO, and you can read the definition yourself, but I think the important things to look at are the impact on somebody in terms of their cognition, their ability to sort of carry out tasks, their ability to sort of regulate their emotions, and then their behaviours, and the fact that it causes significant distress, impairment, and it impacts on their functioning. So really, with mental illness, it's the impact on somebody's day-to-day functioning that is the key issue often. And also, so why is it important to think about mental illness? So it's something that will affect everybody. I will get older. We will all become older at some point. So we kind of have to think about it. It's kind of, not something we can escape. So even if we can't think about it when we're young, it's still something that's going to affect us. And we know that the global population is actually aging very quickly. So I think in 2020, about 1 billion people in the world were 60 or over. And that's in a population, I think the world global population is about 8 billion, just over 8 billion. So and we know that that is going to be rising more. So it's it's a significant proportion of our population. It's a very important thing for us to think about. And about 14% of adults aged 60 and over will actually have a mental disorder. So again, it's important to think about that population. The most common conditions are depression and anxiety. And often I think like Zetu had mentioned earlier, is that the issue is that it's often stigmatized, and it's obviously not recognized in the same way because people forget about older people. They often are sort of much more isolated and keep to themselves. So we don't always necessarily pick it up, even though the mental illness exists and is there. So in terms of diagnosis, I've sort of put a few diagnoses which I think are similar to what we'd see in adults, and they're still relevant in older adults. And I've also just put at the bottom sort of dementia and delirium. So dementia in itself isn't a mental illness, but it's a neurodegenerative disease. But there can be a lot of overlap, and often sometimes it can be difficult to tease apart. Is somebody got a cognitive problem, a dementia, or have they got a mental illness? And you'll have to often think about, understanding what the person has experienced throughout their lives. Have they had, mental illness earlier in their life that they've suffered throughout life? Have there been, certain traumatic events or things that have affected them in their lives? And all of those things tend to be interconnected. So in terms of symptoms, I've done a sort of a little overview of what kind of symptoms you might expect in mental illness, because even with all these diagnoses on the previous slide, you probably get a bit of overlap between all of these things. So things like, in depression, you'll have a low mood. Often people will, not be sort of eating as well. Their sleep will be affected. The energy levels will be sort of reduced. People will experience suicidal thoughts. You often can get a sort of overlap between depression and anxiety as well. So with anxiety, people tend to have a sort of a fear or worry that's in excess of what would be sort of normally expected in certain situations. And then you have also sort of psychotic symptoms. So that's where people will have maybe some delusional beliefs, so beliefs which things that are happening which are not real, but they're very fixed and believe that those things are actually happening. And then you can have symptoms like sort of loss of interest in activities. So people will find that things that they used to enjoy doing, they don't like doing anymore. So whereas they may have been very active and enjoyed, going out and engaging in certain hobbies, they just don't have the interest in that anymore. And that can sometimes be difficult to figure out, is it because they're actually not as physically able, or is it because they're actually depressed? Because sometimes with older adults, there's other reasons why they can't do things, limiting their ability to do things. A lot of older people tend to become more isolated if people don't have a big sort of family network or network of friends, or maybe they've been bereaved. That can lead to them sort of being much more isolated. When you're not working, after you retire, perhaps you're not going to be necessarily going out and seeing the outside world in the same way as you were before. Also thinking about, I talked about functioning. So if your mental health is impacted, you're less able to attend or care about your sort of appearance, and you may not be paying attention to making sure you get washed and dressed in the same way. Sometimes that can also be because you're physically not able to. So sometimes it can be a bit of both, a combination, and it's not always straightforward. And then obviously things like memory problems, which can come with dementia. but it can also come with things like depression. So somebody who's severely depressed will often be have memory problems, but then also have poor poor concentration, poor attention. And then suicidal thoughts is quite an important thing to think about, because actually older people do have suicidal thoughts and they can be at risk of taking their own life. In fact, actually, it's something that you have to take quite seriously, because often, particularly in men, there can be a higher risk. And also, if there is a history of substance misuse, so alcohol or drugs, that can increase that risk as well. So, and you may already know this, but actually talking or asking people about suicide isn't going to increase their risk of committing suicide. It's more about making sure you share and are open about these things and checking in with somebody. And then in terms of the severity of mental illness, so this can range from people, a healthy individual, to sort of mild, moderate, or severe symptoms. So people may experience sort of just mild anxiety or mild sort of depressive symptoms, and that's quite a bit easier to treat. Sometimes you don't even necessarily need medication for sort of like the milder forms, but when it's becoming more moderate and severe, you need more substantial sort of interventions to help support that person. And obviously, the more severe it becomes, the more it impacts on their sort of functional abilities to do things day to day, and the level of distress that it causes a person as well. So just again, just some of the diagnoses that I mentioned. So depression. So the symptoms that you would sort of probably observe, or somebody might tell you about, because some of the symptoms somebody will say, I'm feeling like this. Sometimes they might not, and older people tend to probably be, not everybody's the same, but older people tend to be more closed and perhaps have some more shame about talking about some of these things. So it might be things that you observe as an outsider, that you notice that they seem quite flat and aren't talking as much as they used to. They're not eating as well. They're not doing things they used to enjoy. They're not getting washed. They're not getting dressed. They're sort of neglecting themselves. Sometimes there's a term called pseudo dementia, so where somebody can appear like they have dementia, but actually it's due to the severe depression. And in some ways it can be reassuring, because we know that that's probably easier to treat and reversible, compared to dementia, which unfortunately is a progressive condition. And then older people also can be at risk of a sort of psychosis. Things like schizophrenia, psychosis tend to sort of affect people when they're much younger, but older people can be at risk. And they will present sort of with sort of a range of symptoms. So things like paranoid delusions. So sometimes they might be paranoid about people either trying to spy on them through the walls of where they're living. Often they can have some quite bizarre sort of beliefs about things that are happening within their home. They can sometimes be hearing voices. It tends to be hearing voices rather than seeing things, but people can have visual hallucinations. Visual hallucinations tend to be probably more common if there's a sort of some other neurological conditions. So sometimes if people have like a Parkinson's type Lewy body dementia, then they're more likely to have visual hallucinations. Again, with all types of psychosis, so similar to depression, you also have self-neglect. People become withdrawn, isolated, to keeping to themselves. They're not sleeping well. They can also have a low mood because they're hearing voices which could be saying some very negative things about them, and then therefore impacting on their mood. And sometimes often people who are psychotic will have quite sort of disordered and illogical thought processes. So it might actually be quite difficult to understand what they're saying. again, that can sometimes have a bit of an overlap, can be a bit confusing with something like dementia or like a delirium, which I will explain a little bit later. Are there any questions at this point at all before I go on a bit further?
Seems like we're following you.
Good, perfect. Okay, I'm just making sure I've not like disconnected or anything. Good.
Okay.
So in terms of causes of mental illness, so we tend to break things up into sort of what we call biological, psychological, and social factors. I mean, these are sort of the theories that we base our sort of understanding and our treatments on. So when we talk about the biological factors, we're talking about brain changes, genetic factors. So those are, brain changes that exist which predispose people to having a mental illness. And often, mental illnesses will tend to have, run in families. There's also the psychological aspect. So thinking about the thoughts we have, how we, with our emotions, the behaviours, and how we react to what we experience in life, and what our coping mechanisms are. And then the social factors, which are the things we experience. So environmental factors. So often, if and this actually I come across this quite a lot, is that older people will have experienced quite significant adversity in their earlier life, in their childhood, and have had trauma, abuse, and things like that, which have impacted a lot on them. And then risk factors, which are quite important in older adults, are things like bereavement. So I've come across a lot of patients who will have been bereaved. They've lost a partner, a husband, wife. Sadly, actually, with the COVID pandemic, I found that that's happened quite a lot. So I've come across quite a lot of patients who've ended up alone, and that's quite a difficult thing to manage, depending on what other support network is around. But if you've also lived such a long time with somebody, that's quite a drastic change as well. Things like reduced independence. So because of that, can be because of physical illness, sort of you're not as mobile as you used to be. You're reliant on other people. Perhaps maybe you're not allowed to drive anymore. So that can, all of those things can really restrict your life a lot, and perhaps lack of activities. So whereas you might have been working, all the time before, going out of the house because you have to go to work, now you're not necessarily got that structure. So unless you already had things outside of work that you were doing, you might not have the same sort of drive to be doing things on a day-to-day basis. And then there's things like, also, unfortunately, older adults can be at risk of abuse from others, and that can even sometimes be carers and family. But it's something to keep in mind as well, because they might not, again, be able to talk about it. So in terms of treatments, I'm not going to go into lots and lots of detail about it. But again, it's talking about these three things: so the biological, the psychological, and the social factors. So with medication, you've got antidepressants and antipsychotics, and there's some other medication types as well that we can use. And we know that medication can work, but we are still understanding and learning about the brain. So there's lots of things that we don't fully understand. Sometimes it works very well for some people and not as well for other people. And it's important to have a bit of a balance when thinking about treatments, and thinking one thing's not going to solve everything. You have to try and look at things holistically as well. And also with medication, you have to think about things like side effects. So no medication comes without side effects, which is why it's really important to balance that and have a good conversation with a doctor, with a nurse, with a healthcare professional about that. And also with the other thing with medication. So for when I talked about the sort of the range and severity. So for people who maybe have just a mild depressive episodes, they may not need antidepressants. They may benefit from just either psychological interventions or social interventions. So in terms of psychology, that can be sort of talking therapy, counselling. There are various types of psychological interventions depending on what the presentation is. And then something I think is actually very important as well is like the sort of social support network that people are connected with. So thinking about joining activities and either continuing things that the person used to do and seeing if those things can be reignited, or finding other other interests. So sometimes there's sort of can be day centres, there can be arts or music groups, gardening groups. One thing I've heard of that's sounds quite interesting is something called the University of the Third Age. So that's where people who are older will sort of run sort of educational groups on topics. Maybe, I don't know, they studied science, engineering, or mathematics, all sorts of things, and they will share that information because it's a way of sort of continuing to keep them sort of cognitively engaged, but also sharing their knowledge with other people. And that can be quite a beneficial thing. There's befriending schemes. In the hospital I worked in, we had a sort of, it's called something called a pat dog scheme. So that's where you had somebody who's with a specially trained dog would come in to visit the patients on a weekly basis. And you could just see the therapeutic value in that, because sometimes patients who, particularly maybe even dementia, but not just dementia, for other mental illnesses as well, there's something therapeutic about animals for some people, not necessarily for everyone. And another project which was quite nice locally was there was a schools intergenerational project. So that's where they had sort of older people who had mental illness would be sort of engaging with groups with a primary school locally, and they would do sort of activities together, supervised, and there was a real sort of like benefit not just for the older adults but for the children as well, because that sort of spending time sharing sort of things together was actually really quite beneficial. And then a bit about the physical health aspects. So with older adults, there is sort of a risk of increased frailty. So frailty is sort of somebody's ability to be able to bounce back from certain physical health and mental health sort of illnesses. And as people get older, their ability to do that the capacity to do that is deteriorate, so they're less able to. But again, it varies from person to person. So not everybody is necessarily frail just because they're over the age of 65. It varies from person to person. There's some people in their 70s who are not frail, and some people who are in their 60s who are very frail. Things that are important to think about are things like sensory impairments. We talk about this in dementia patients as well. So people will often have worsening hearing, eyesight, and those can impact on a person's just enjoyment in life. It can also impact on how they perceive the world around them. Mobility, so with people will be less able to sort of walk around. Sometimes they may have had arthritis, they may have chronic pain which limits their ability to be as mobile, and they might have other conditions as well which affect that. There then be a sort of an increased risk of falls, and that can also contribute to things like people developing anxiety because they become anxious about falling and hurting themselves, and then probably don't try and go out, and then they end up becoming much more isolated. So you have to think about how do we try and change that sort of pattern. And then often people will develop further medical illnesses, so there'll be a risk of sort of cardiovascular disease, having high blood pressure, high cholesterol. increased risk of stroke, diabetes, kidney disease, cancer. Chronic pain is an issue, so that can then affect somebody's quality of life because it's just very uncomfortable and debilitating. Incontinence as well, so that can be a reason that people don't go out because they're worried about being unable to go to the toilet, or they're embarrassed. And just having making sure that all of these aspects of someone's physical health is tried to be addressed is actually incredibly important. And being able to talk with professionals, it can be a nurse specialist, can be the general practitioner, family doctor. It's just important to think, okay, how do we try and target each of these things, little bits that can actually make somebody feel a bit more confident, a bit happier. And it's not all, again, it's just not about medication. It's just about trying to, sometimes it might be, but sometimes it's about trying to target specific things. And then delirium. So I don't know if people know much about delirium already, if that's something I can speak a bit more about. Does anyone know what?
I think I mean, some people, not everybody here, but I think it's a good a topic if you can just sort of talk a bit more, because usually it's carers who've got to understand what is delirium so that they can be able to support their relatives. So if you can please say more.
So delirium is something that's it's really relevant for older adults, mental illness or no mental illness, because it happens, with people who've got physical health problems. Even, I mean, younger people can get delirium as well, but older people are much more prone to getting it. Essentially, what it is, it's called an acute confusional state. But when somebody develops a sudden onset of a change in behavior, becoming incredibly confused, and they're not their usual self. And it is a state that can be triggered by things. Often it is an infection, but sometimes it can be things like new medication. It can sometimes be triggered by things like, dehydration, malnutrition, constipation. But important things to try and understand. So if somebody particularly if they're older, suddenly develops a change in their cognition, their behaviour that's very out of character, and they're behaving bizarrely, it's important to think about something like a delirium and whether there could be an infection, and urgently getting medical help to look for what that source of infection could be. Could be they have a chest infection, they could have a urine infection. It could be something more, more complicated, but sometimes even just a simple urine infection can cause a delirium, and that person may need antibiotics. Sometimes if it's more serious, they may need hospital admission. But the difference with delirium is that it can be reversed if it's treated appropriately. But sometimes older adults will be at risk of having repeated episodes of delirium, and the more often they get it, it can then impact sometimes on their general functioning and mental and physical health as well. And so these are thinking about the team that will be involved in trying to support older adults. So there's lots of people who can help, and I think it's really important having, you have teams on the hospital wards, in the community, having, all these different specialists who can talk to each other and think about the patient and how they can work on different factors to help, thinking about both mental and physical health hand in hand. And sometimes, this depends on the team, how lucky you are to have, if it would be great if all teams could have a full complement of these specialists. So in terms of understanding mental illness in people that we care for, relatives, I just say to emphasize the importance of communicating and taking time, because older people will take time to be able to express themselves. You need to be quite patient and non-judgmental, and particularly if people might be having some delusional thoughts or some odd bizarre thoughts or hearing things, you really have to try and take a step back and not sort of jump to judge things, because people might say odd things. It doesn't mean that you have to agree with what they're saying, particularly if it's something very strange, but also trying to not challenge. Sometimes challenging things isn't always helpful. Also having patience, being calm, and realizing that mental illness, whilst people can get better, it can often take time, and it's about working together to try and improve things. I think it's important to make sure we try and empower older people to be able to sort of make decisions where they can about their own life and their care and treatment. Trying to share understanding, improve understanding for everybody involved, and important to advocate for them, because some older adults aren't able to talk for themselves, so we have to be the ones who advocate for them, and think about living situations. Where are people living as well? Where would they like to live? Because that can impact a lot. Sometimes, often people end up in care homes, but that's not always necessarily the best setting, unfortunately. So you really have to think, well, what does a person want? What would they have wanted if they could have made that decision? And also, so finally, just again emphasising the importance of social connectivity, the network, and what the support network looks like for that person, what helps improve their quality of life and makes it meaningful. And then just last a little bit about the impact on carers and family, because whilst it can be quite rewarding, caring for others, it also comes with it a lot of stress, and often people can experience their own burnout and then have impact on their own mental health as well. So it's really important to make sure that you access sort of help and support. And there's often charities and community groups which are very, very good, actually. But it's about sort of having access to those things and being able to sort of collect sort of a list of services available. Often sort of barriers to accessing help can be that the patient themselves doesn't recognise an illness. There can be because of stigma, because of shame. So trying to encourage somebody can be quite challenging. Sometimes there is just limited access to that kind of support, so it's really can be quite a challenge to actually try and get the right support, and take time and a lot of patience. And that, I think, is the end of my talk. Are there any questions at all?
Well, thank you so much. Thanks a lot. I think we need to open it up. I'm very, very keen, Dr. Solomon, if you can go back and talk about what schizophrenia is. And I'm saying, I know what it is, obviously, but for the benefit of people who are here, and also bipolar. Me and Madan, we always kind of like think, oh, everybody's got bipolar in South Africa, because people use that word very, very loosely. And what is schizophrenia? Of course, if you've got schizophrenia, people sometimes can't even pronounce that word. I know that is kind of a bit of a mouthful, but I think for me, if you can sort of simplify it, what is it? And also, what is the treatment for that illness? And also psychosis and bipolar, because sometimes what is bipolar? If you can just simplify it for the purpose of
so I'll start
meeting,
with I'll start with schizophrenia and psychosis, and then I'll go on to bipolar. So schizophrenia is essentially actually a type of psychosis. I think one thing we have to be aware of in mental illness is that terminology and words change. So things that will have been used historically have changed a bit, but so schizophrenia essentially, the word actually means split mind. So it is an illness where people will experience delusions. Often they are paranoid delusions, where people either think that somebody's trying to harm them. They might think, somebody's trying to poison their food. They might think somebody's trying to follow them. They might sometimes believe that people are talking to them through the television, because they're hearing things, or they're hearing voices, people talking about them, again, possibly saying negative things. They will often have disorganized thoughts, and and will be sort of maybe jumping around in terms of their thoughts. The things that you might observe as it's very sort of nonsensical sort of thought content. And so that's schizophrenia. Psychosis in itself is kind of includes some of those symptoms. So we would still say that somebody who's schizophrenia is psychotic. So again, the terms are a bit confusing. And one psychiatrist might say somebody, oh yeah, you've got schizophrenia. Another one might just say you've got psychosis. So I'd say they're used interchangeably, but it might sometimes depend on the psychiatrist or the doctor. Ultimately, usually the treatment will be similar. So the best treatment we have available at the moment is antipsychotic medication. And they can be effective, but they also come with quite a lot of side effects, and that's one of the issues, is that a lot of the side effects, things like weight gain, increased risk of diabetes, which means that there's that sort of an impact of that people don't want to take the medication because of side effects, and having that balance of, well, knowing that with it's helping that person, you need to balance their quality of life versus those side effects. So that's having an honest conversation. And there are, some of the newer medications are a bit better, but it's still not perfect. You can have some psychological interventions for specifically for psychotic symptoms and hearing voices. Again, it doesn't necessarily focus around challenging ideas, but it's all around trying to maybe help with psychoeducation for the patient, but also the people around them as well, because sometimes those beliefs won't necessarily always go. So that's schizophrenia and psychosis. Is that okay, Zetu? Yeah.
So I muted myself. I mean, I don't know whether people may want kind of more clarity, or are people happy with what Dr. Solomon has described as schizophrenia? Sorry, Matanda, you saying something?
No, I wasn't.
Oh, sorry, I wasn't. Okay, so for me, I don't mind asking questions on behalf of people, because obviously we always have this kind of regular conversation with people. But in terms, so Nompilo has raised a hand. Nompilo, please go ahead.
Greetings, everyone. Thank you, Dr. Solomon, for your informative presentation. Yeah, I have learned a lot. I just have a question, right? I have a patient. I started seeing her last year, and she deteriorated quite significantly over a few months.